We'll talk about the sources of these cytokines and strategies to lower cytokines in order to prevent the development of symptoms. And we'll also highlight 2 clinical trials at Sunnybrook that might be of interest to this audience. So all cancers develop in 3 stages. First is initiation. The cell of origin of the cancer develops genetic mutations that essentially immortalize it, but that initial step doesn't really cause any problems. Where the problems come in is when factors called promoter factors stimulate these initiated cells to grow, and as they grow, they acquire additional genetic mutations that make them more aggressive, allow them to grow uncontrollably, cause damage to healthy tissues, and cause problems for the patient. So in CLL, the cell of origin is a B cell. And so I have to tell you a little bit about B cell biology to understand CLL. So B cells are lymphocytes, white cells, that arise in the bone marrow. And they come out of the bone marrow and they traffic in the blood to regions in the body called lymph nodes and the spleen and back to the bone marrow. And why do they do this? They do this because their job is to fight infections. So they express on their surface a molecule called the B cell receptor. And the B cell receptor represents target molecules, abnormal molecules that are found on the surface of infectious agents like bacteria and viruses. And so there are millions of different potential targets on these microorganisms, and consequently there's millions of different B cell receptors. And so as the B cell is trafficking through the body in and out of lymph nodes and spleen, if it sees a foreign antigen, and it sees the right foreign antigen that it's able to recognize, what will happen is the antigen will, and the antigen is the name of these molecules on the microorganisms. When the B cell receptor sees its antigen, the B cell receptor will send signals into the cell and cause it to proliferate to large numbers, and then this is called activation of a B cell, and the activated B cell then produces soluble multiple copies of its B cell receptor, which it secretes. And these are called immunoglobulins, and these multiple immunoglobulins then bind to the microorganism and inactivate it. And that's how that's basically how B cells play a role in the body. And so during these processes, what happens is that somewhere along this biology, this lifespan of a B cell, genetic mutations are acquired which cause which immortalize the B cell and then cause it to eventually lead to CLL. And so somewhere along the line, probably about 10 or 15 years before you get the diagnosis of CLL, in this process, somewhere along the line, a B cell has gotten transformed. And then over time, these promoter factors stimulate the growth of the B cells such that it's able to come out into the bloodstream and you can recognize it. And how you recognize it is you go to your family doctor, generally most of the time, and he does your annual blood work and finds that your lymphocyte count is a little bit elevated. And then if the lymphocyte count remains elevated for a few months, then usually the patient is then sent off to a hematologist, and the hematologist does a test called flow cytometry, which to look at what types of lymphocytes are actually increased in your blood. And normally, when you do this flow cytometry, there's a population of B cells called CD5 positive CD19 B cells that are generally found at very low levels in the blood. But if you see an increase in these types of cells, that generally makes the diagnosis of CLL. So this is a complicated slide, but I wanted to put it in because we've talked about how CLL arises from immortalization, and this immortalization comes about because of damage to genes, to genetic mutations in genes. And so in the last actually few years, using technology called RNA sequencing, next generation RNA sequencing and next generation DNA sequencing. This is the same sort of technology that's used for these 23andMe type commercial assays that you can get to find out what your heritage is. But using that same type of technology, it's been identified that there's really only about 40 or 50 different genetic mutations that actually cause CLL. I'm not going to ask you to remember them, but these genetic mutations occur in certain types of genes that are involved in these processes of proliferation and death. So, for example, some of them are involved in the signaling through the B cell receptor and the B cell receptor's actions, and they get mutated so that they're always on. So instead of the B cell receptor just getting turned on when it sees an infection, it gets turned on all the time. So it's chronically on, always dividing. Similarly, in the process of the body has evolved to develop defense mechanisms to prevent the development of genetic mutations. So it's not good for a cell to have lots of genetic mutations. So there are systems set up that if the cell has too many genetic mutations, it'll die. If that was the case, you'd never get a cancer. So what happens is you get a damage to proteins and genes that are involved in this pathway called DNA damage and cell cycle control. And these get knocked out, so you don't have these defense mechanisms. And again, allowing these genetically mutant cells to continue to grow. There's one other mutation that you need to appreciate to understand CLL, and that is that there are the B cell receptor can exist in two stages. In B cells that come out of the bone marrow, the B cell receptor is composed of the same genes that are found in any other cell. When the B cell sees its antigen in lymph nodes and spleen, there's a physiological mutation that occurs. This is not a bad mutation, this is a good mutation. The mutations I talked about in the previous slide, those are bad mutations. What mutations specifically of the B cell receptor do is that they make the B cell receptor to be able to bind more strongly to its antigen. And so this is just a process called somatic mutation, but what it means is that there are essentially two major subtypes of CLL. Those with the unmutated immunoglobulin receptor, we call it IGHV unmutated, or the B cell receptor mutated, call it the IGHV mutated. Again, this is different. All the CLL cells carry mutations in non-B cell receptor genes. When we refer to CLL cells as being mutated or unmutated, it's specifically about the B cell receptor. And generally what it means is that the unmutated ones generally probably arose from cells that were just coming out of the bone marrow, whereas the mutated CLL cells arose from cells that were already in lymph nodes and bone marrow. And so I've talked about how CLL is dependent on multiple different mutated oncogenes, meaning these genes that cause unrestrained proliferation, and that B cell receptor can be mutated or unmutated. So you can see there's not every CLL is sort of different. Every CLL patient is a little bit different. And these different mutations give a different biology to the CLL cell. So some patients with certain mutations have a very indolent course, very benign course. Others have a very rapidly progressive course. And that's encoded or predetermined by this collection of damaged genes that drive the CLL cell. So as an example of this is a slide actually from 2007. So this is well before we had all of the new drugs we have that will be talked about in the next section, which have changed this slide dramatically. But what it indicates, what was done here is taken all CLL patients at the time of diagnosis and then followed them over time to see how long they lived, and correlating that with different genetic mutations. So if the B cell receptor was mutated, those patients had a very sort of indolent course. So after even almost 20 years, most of these patients were alive. If the unmutated immunoglobulin receptor subtype of CLL grows faster, has what we call a more aggressive course, and so more of those patients would die more quickly. deletion genes, if there was a region of chromosome 11 that was deleted, this encodes an important gene involved in DNA repair, so it gets knocked out. That type of disease grew faster. And the fastest growing type of CLL had a region of chromosome 17 knocked out, which encodes a gene called P53, and that is a sort of a master regulator of cell growth and DNA repair, so it's important to knock that out. So this slide is not meant to scare you, it's basically just to show you that the biology of CLL cells are very different. In those days, we really didn't have good treatments for these types of CLL subtypes. Now we do. So this slide is really out of date. So just to sort of summarize differences in CLL, some of the things that you can measure to tell you how if aggressive or how slow growing your CLL cell will be, are to look at things like these changes in chromosomes. So we've talked about the 17p and 11q deletions. You can measure some of these newer genes that are knocked out in CLL, that are involved in CLL growth. There are certain proteins on the cell surface of the CLL cell that can be measured, and if they're at higher levels like CD38 or ZAP70 or CD49, they tend to be expressed at higher levels on cells that grow faster. An important marker that we look at in the clinic is the beta-2 microglobulin. This is a molecule that we measure in the blood of patients, and if it's high, that tends to again correlate with a more aggressive or more rapidly growing tumor cells. These other markers, soluble 23 and thymidine kinase, are things we don't measure in North America. They're more measured in Europe. The easiest way, and probably the most reliable way to tell how good or bad your CLL is to just establish the lymphocyte doubling time. And what this is very simply, your doctor should, at time of diagnosis, should see you a few times a year and looks at your white blood cell count, which indicates this amount of CLL cells in your blood. And if that increases, doubles within a year, you're pretty well sure that you're going to need some treatment in the next few years. If it takes 5 or 6 years to double, you may not even need treatment in your lifetime. So this is the life cycle of a CLL B cell. So it's basically a paradigm, or much like the life cycle of a normal B cell. CLL cells traffic in the blood, but where the action is, or where the problems arise, are in the bone marrow, lymph nodes, and spleen, where the CLL cell goes into these areas and receives the signals which tell it to divide a few times, and then it's released out into the blood, and this process gets repeated over and over again. And the more aggressive CLL cells, with the genetic changes that cause them to be more aggressive, they respond much more strongly to these signals, grow much faster, and that's why patients accumulate many more CLL cells in that case. And the other point of this is that we measure cells in the blood, CLL cells in the blood. That's the easiest thing to measure. But that's not really what we're really interested in terms of trying to control the disease. Control of the disease involves controlling growth of the CLL cells in these areas. And it's very difficult to access those regions. It's easy to get blood tests every time you come to clinic, but it's hard to take a piece of your lymph node, hard to take a piece of your bone marrow, hard to take a piece of your spleen on a regular basis. So that's why we use models of the microenvironment, and I think that Dr. Andrews talked to you a lot about that in the previous slide. So with that as a background, this is the typical clinical course of a patient. And so from the time of diagnosis, we don't treat until the patient develops symptoms. And so this period is called the watch and wait period. Subsequent to the development of symptoms and first-line treatments, you'll encounter all the drugs that will be talked about in the next section. But what we're going to be concerned with here is, why do symptoms develop during this period of time, and how can you avoid them? So CLL really becomes a problem only when the leukemia cells grow to large enough numbers or acquire properties such that they damage normal organs. And the organ that's mainly affected to cause problems in CLL is the bone marrow. So the bone marrow is found in bones of the body, and it's where cells of the blood are made. And so these cells of the blood include red cells, which carry oxygen, platelets, which help prevent against clotting. Importantly, other B cells, which we've discussed about, which help fight infection, and others. There are other cells in the bone marrow called monocytes and macrophages and neutrophils that are also involved in fighting infections. And so, as CLL cells grow, they impact this organ function, and how you see that is you start to lose production of red cells, so you become anemic. You start to lose production of platelets, so you become what we call thrombocytopenic. And importantly, and we'll talk about this a lot, you impair the ability to make of the normal B cells to function, and you impair your ability to fight infections. So, how many CLL cells are required to do this? To what greater degree can CLL cells grow before they start to cause problems, start to cause symptoms? And this depends on the underlying genetic changes in the leukemia cell, and perhaps the psychological makeup of the patient. So some people appreciate symptoms more than others. Importantly, there's a subgroup of CLL patients. It's not an insignificant subgroup that really has an indolent form of disease that never requires treatment. These patients basically have no enlarged spleens, no enlarged lymph nodes. They don't develop anemia. They retain normal immune function. And sort of a marker for this is their white blood cell counts never go above 30. Normal white blood cell counts are between 4 and 10. So there is this subgroup of patients in which the diagnosis of CLL is really no more than the diagnosis of a wart on your skin. And it's important to make that distinction. But in general, if the white blood cell count increases to quite a high level, so of the order of 200 to 300 times 10 to the 6 per mil, with anemia, then treatment is inevitable. So, and again, the normal white blood cell count is less than 10. So what are the general symptoms in CLL? Generally, the symptoms in CLL are fatigue, and this is probably the biggest symptom, but it's often associated with anemia. Fevers and night sweats occur as the CLL progresses. Unexplained weight loss can be attributed to CLL. There's not really a lot of pain associated with CLL. Probably if the spleen gets too large, you can get some abdominal pain. Enlarged lymph nodes are generally painless. And a major symptom in CLL is recurrent infections. So what causes these symptoms? Well, actually the symptoms in CLL are due mainly to high levels of cytokines, as we mentioned. What are cytokines? They're inflammatory factors. They're part of the body's defense system. They include molecules that have names like interleukin-1, interferon, tumor necrosis factor, interleukin-6, interleukin-10. There's actually several hundred of these types of molecules. In the short term, what they do is they help protect your body against stress, particularly infection. So if you're deficient in these molecules, you have problems with infections. However, if these molecules are in the blood for long periods of time at high levels, they can damage organs and then make you feel sick. And so this is sort of an indication that CLL patients generally have higher levels of these molecules like TNF and IL-10 in their blood compared with normal patients. So these are normal levels, and these are in a population of CLL patients. How do they cause the signs and symptoms of CLL? Well, we've said a lot of the problems in CLL occur in the bone marrow. So in the bone marrow, the normal stem cells that produce platelets, B cells, red cells, as CLL cells grow, there can be high levels of these inflammatory cytokines in the bone marrow, which both paralyze the normal hematopoietic. These are the normal hematopoietic cells. These are the CLL cells, and you can paralyze the normal hematopoietic cells, and moreover, the inflammatory factors can help stimulate the growth of the CLL cells, so that the CLL cells can overtake the marrow, squeeze out the healthy stem cells, healthy bone marrow cells, and then lead to then the symptoms of CLL, the drop in platelets, the drop in red cells that cause anemia, and importantly, the drop in normal B cells that make antibodies. These cytokines, high levels of these cytokines can act on many tissues, not just the bone marrow. They can act on the muscle. They can to cause weakness. They can act on fat cells to cause fat cells to release their contents, to support the growth of CLL cells, and that's responsible for some of the weight loss that's seen with symptomatic CLL. They can act on the brain to cause decreased appetite, depression, so they can also cause the fever, the night sweats, particularly this molecule called IL-1. If it's at high levels in the blood, that can cause the night sweats that people can sometimes get at nighttime. So high levels of cytokines can explain a lot of the constitutional symptoms of CLL. Another major symptom in CLL is recurrent infections, and this is often caused by impairment of the normal B cell system and low immunoglobulins. So hypogammaglobulinemia is characterized by low levels of functional immunoglobulins. And just recall again, normal B cells come out of the bone marrow. When they see antigen, they proliferate, they secrete lots of soluble B cell receptors, and these are slightly altered. They have slightly different structures, and so we call these solubilized B cell receptors molecules such as IgM, IgG, IgA. There's 3 of these types of immunoglobulins or solubilized B cell receptors in the blood. Normally, these levels for IgG are between 6 and 16, IgA between 0.7 and 4 grams per liter, and IgM between 0.4 and 2.5. But with CLL, these numbers fall, and that's because of the impairment of CLL cells, how it impairs the development of B cells to be able to go through these pathways to be able to make these immunoglobulins. So this, what we a couple of years ago, we actually looked at immunoglobulin levels in our patients, and we would see patterns that looked like this. So here's an example of a patient who was diagnosed in 2001. She had a very low level of white blood cell count, 4.1, the normal being about 2.5. This led to her diagnosis of CLL. As you can see, she went until about 2008, really with not much in the way of changes in her white blood cell count. But then her white blood cell count started to increase. And so what this probably meant is that she acquired more of these mutations that transform CLLs, make them more aggressive. The more mutations you have, the more aggressive generally the CLL cells. So now her CLL cells start to grow. And as you can see, concomitant with that, her immunoglobulin levels, which had been fairly stable when the CLL cells was very, very indolent, then all of them started to drop in unison. And so we see that pattern, those variations in this pattern all the time. And we've noticed that if the IgG level seems to remains above a number of 8 grams per liter, remember the normal is 6 to 16, that's generally associated with benign disease. But if the IgG levels fall below 6, that generally is associated with the development of symptoms. So, okay, the symptoms in CLL are often related to high levels of inflammatory cytokines. Where do they come from? And so oftentimes they come from the CLL cells themselves. So remember this figure where the CLL cells, biology is dynamic. The CLL cells come into the blood and then go back into the microenvironments in lymph nodes, spleen, and bone marrow where they get activated. And in this process of activation where they proliferate, they also make cytokines. In addition, they interact with other cells in these microenvironments, non-CLL cells, normal cells like other cells of the immune system or supporting cells called fibroblasts. And these cells also make cytokines. Another probably major source of cytokines in CLL is actually from being overweight, from having too big of an abdominal fat pad. The abdominal fat pad basically means that fat cells in the body are engorged with excess fat and stretched. So the fat cells get stretched. And when they get stretched, they secrete stress molecules. They get stressed by being stretched. And so they release factors like TNF and like IL-6. And moreover, they'll also bring in other cells of the immune system called macrophages, and they will also stimulate the production of these inflammatory cytokines. One of the ways you can that being overweight manifests is by having too much of a lipid molecule called cholesterol in the blood. So if you're overweight, you often have high levels of cholesterol in your blood. And we actually think at Sunnybrook that CLL may actually even be a complication of having too much cholesterol in your blood. We found that nearly 80% of CLL patients in Ontario have evidence of high cholesterol levels in their blood, as compared with a control group of normal would be about 25% of patients. And we did some work, actually that was supported somewhat by the Leukemia and Lymphoma Society, that suggested that these high levels of cholesterol in the blood were used by CLL cells to help them grow faster. I've talked about hypogammaglobulinemia, these loss in immunoglobulin levels, as being important in causing symptoms. It can also cause a general state of inflammation. So what this figure is supposed to show is this is your gut and your intestine. And so this is the intestinal, the intestine where food goes through and gets absorbed. But in those intestinal tubes are also millions and millions of bacteria. And if those bacteria would be able to get across the lining of the intestine into the blood, that can make you be quite sick. So B cells, especially the IgA molecules that are part of the immunoglobulin family, are secreted by B cells directly into the lining of the gut, into the lumen of the gut, the opening where the food is. And what they do is they actually bind to bacteria and keep them localized in the lumen and not let them cross into the bloodstream. But as CLL progresses, these levels can decrease, and that can then allow what we call subclinical infection. So a little bit of leak of bacteria into the blood, not enough to make a full-blown infection, but enough potentially to stimulate the immune system to increase inflammatory cytokines, and these cytokines then can cause symptoms and also stimulate the CLL cells to grow. And finally, what about psychological stress? Is psychological stress a source of cytokines? And the answer is probably yes, to some extent. So this was actually a recent study that came out of the Ohio State University, and they were looking at basically cytokine levels in patients who were about to enroll in some clinical trials at the Ohio State at that time. And patients were asked about cancer-related stress, and some of the questions were how often they had intrusive thoughts about their cancer, how often they tried to avoid thinking about it, and then how often they felt jumpy and easily startled. And the results did show that more stress was associated with a higher number of circulating CLL cells and higher levels of cytokines, which included TNF-alpha. So that's actually a very interesting study, because I know psychological stress, a lot of people would answer yes to these questions. So if high levels of cytokines are responsible for symptoms, what can be done to reduce cytokines and reduce symptoms? So an obvious question or answer would be, well, if the CLL cells are making these cytokines, why don't you just treat at the time of diagnosis, prevent them from developing and prevent the development of symptoms? So treat at time of diagnosis with chemotherapy or with Ibrutinib or venetoclax that you'll hear about right at the time of diagnosis. What's the rationale for watch and wait? So the rationale really is that not all patients require treatment at time of diagnosis. As I've said, there's a large population of patients for which CLL is really a benign condition. But what can be guaranteed, so you wouldn't really benefit those patients by treating them, but what you could guarantee is that you cause symptoms from the treatments. No matter how good we think some of these treatments are, they all have side effects. The other thing is that none of these drugs cure, even the newer ones. And so, at least in most cases, they don't cure. And so what's happening then is, if by early treatment, the CLL cells you'll select for basically more aggressive CLL cells, those with more aggressive mutations that can survive the treatment. And what you'll do by early treatment is select for more aggressive treatment with over time, and you may in fact shorten a patient's life by treating too early. And in fact, years ago, even before the newer treatments were available, it was shown that studies of treatment at diagnosis versus treatment on indication on the development of symptoms resulted in no difference in survival. So, okay, if cytokines are causing symptoms, why not just give a drug to block the effects of cytokines? And this has been done. So many cytokines act on cells to cause symptoms. And how they act on cells is they bind to the cell that they're going to cause damage to, and they and then they activate a family of proteins called JAKs, which basically cause the effects on cells throughout the body that are responsible for symptoms. So why not just block the JAKs? And so there is a molecule called ruxolitinib, which is a kinase, it's just a drug that you can take. And so the question would be, what happens if you would give a CLL patient ruxolitinib? And this was done. This was a study from the MD Anderson a couple of years ago. And what was done is they took CLL patients who were in the watch and wait period of time, and they gave them ruxolitinib, and they asked about changes in fatigue. So the patients would report how they felt on this drug. And so a line down like this represents that their fatigue improved. And so you can see in most patients, fatigue improved quite significantly on this drug. And so what that tells you, it tells you that ruxolitinib improved fatigue and assures you that the cytokines that activate JAKs definitely cause fatigue in CLL patients. However, we did the same study in more aggressive patients who were later on. They're still in the watch and wait period, but a little bit later on in their disease course. And we saw actually that ruxolitinib accelerated disease. So patients felt better, but their disease was growing faster. And this sort of shows what we saw. So basically, compared to starting the drug, white blood cell counts increased in the blood. A marker called LDH, which is a marker of cellular activation, increased. Fortunately, the minute you stopped the drug, everything went away. But what this taught us was that cytokines certainly cause symptoms, but one of the reasons they're there is they're also helping suppress tumor growth. So ruxolitinib, though, can be used very safely in the presence of ibrutinib, a drug that you're going to hear about later. So we're actually have a trial at Sunnybrook where we're adding ruxolitinib to ibrutinib to try and improve the results of ibrutinib. And this seems to be an effective approach. This study is recruiting patients right now. So basically anyone on ibrutinib or about to start ibrutinib would be eligible for this study. And we would certainly be interested to tell you more about it and potentially see you in the clinic. So, okay, so it's not good to treat at diagnosis. It's probably not good to treat with ruxolitinib as a single agent. What else can you do to decrease inflammatory cytokines? The best tool in your armamentarium to decrease cytokines is exercise. So if you're exercising sufficiently that your muscles are getting stronger, your muscles will actually secrete factors that actually block these inflammatory factors, as well as weight loss, which will also lower inflammatory factors. Calorie restriction, eating about 25% less than what you normally eat, is well known to decrease cytokines and lead to decreased growth of cancers in general, and presumably CLL in particular, since there's not a lot of difference in the CLL biology with other cancers. Lowering cholesterol. We've said that high levels of cholesterol are often found in CLL. That these high levels of cholesterol can, in fact, help to promote the growth of CLL cells. And this is a result that shows that lowering cholesterol can probably slow the growth of CLL cells by several years and may even increase overall survival. Well, what this was is a study on 10,000 Ontario residents with CLL, and where we could access from administrative records those who were using drugs to lower lipids and those who weren't lowering using such drugs. And this was data from before about 2010. So it was quite a retrospective study. But the point that was made is if CLL patients were on drugs to lower lipids, and cholesterol are lipids, they seemed to survive several years longer than patients who were not on such drugs. And so, again, this is a survival curve done before the institution of the new drugs, and so those survival numbers are not absolute. But what this graph represents is that there really does seem to be an effect of lowering cholesterol levels, particularly in prolonging the growth, prolonging the time before treatment is needed in CLL. So how can you lower cholesterol? Again, weight loss, calorie restriction, and drugs like statins can also be used to do this. Stress, as we've said, might be a cause of might contribute to high levels of cytokines in the blood. It's probably not a major contributor, but it's probably important to reduce stress. Again, one of the best ways to do this is with exercise, but meditation and cognitive behavioral therapy probably have a place in doing this. And so finally, we've really alluded to this idea that CLL cells can cause immunoglobulin levels to fall and predispose to recurrent infections and small infections that can potentially produce inflammatory cytokines that can cause symptoms and can allow CLL cells to grow. And we came up with this number of 8 grams per liter that below which CLL symptoms seem to be inevitable, but above which CLL seems to be mainly a benign disease. So would it make sense to try and artificially keep IgG levels above 8 in the watch and wait period to try and, enforce a sort of a benign phenotype on CLL patients? And so you can do this. You can do this by injecting something called IVIG, intravenous immunoglobulin. What this is, it's a blood product, and what it does is it contains IgG molecules from thousands of healthy donors. So you take their blood, you pool it, you purify the IgG molecules. They contain IgG molecules to lots of different bacteria, and so if you inject it into someone who doesn't have immunoglobulins, it provides protection against bacteria and viruses. So this is a substance that can be injected once a month, like a transfusion in a hospital. You can also inject it yourself once a week. Does it help CLL? In some cases, it might. So this is a patient, a young woman, diagnosed. White count was 29 in 2005. Over the next 5 years, her white count actually increased to 450. And so, and as you can see, then her IgG fell at that time to again, normal is 6 to 16. Hers is 3.88, and she's having multiple infections. So she was put on IVIG. That's her only treatment. She gets it once a month, and you can see that the IVIG is sufficient to keep her IgG levels now around 12. And it's been that way since 2012. And all that's happened with her is that she's continually dropped her white blood cell count. It's now from 450 down to 105. Beta-2 microglobulin, we've said, is associated with more aggressive disease. That just keeps going down, again, only with immunoglobulin infusions, and importantly, keeping the IgG level above 12. So the problem is, so that suggests, well, maybe we should be doing that to patients. Maybe we should be giving them artificial injections of IVIG. Well, unfortunately, that makes no sense at all because it's just not practical. Because it's a blood product, supplies are very limited. The doses you need are probably higher than used conventionally. There's not enough material in the world to do this. Importantly, the injections are cumbersome and the costs are staggering. It costs about $100,000 a year for IV gamma globulin for a year. We can barely keep up with our current indication. So if we wanted to use it in patients just to keep their IgG levels up, it would break the healthcare system. So is there another approach? So this is another picture of a bone marrow. I've given a few in this slide. And these are B cells developing in the bone marrow. And we've said that CLL cells, probably through the production of inflammatory cytokines, suppress the production of normal B cells. So what if you just blocked the major cytokines that potentially are impairing the ability of normal B cells to function? Would that be able to prevent the immunoglobulin levels from falling below 8? So one of the major culprits, at least from basic research, is a molecule called interleukin-1. And interleukin-1 can be blocked by a molecule called ANAKINRA. So we're wondering if we treated patients with ANAKINRA in the watch and wait period of time, would we block IL-1? Would we then free up normal B cell production? And would we then improve the patient's immune response? So ANAKINRA is an IL-1 inhibitor, and it's been used, it's already available in Canada for the last 10 years to treat patients with rheumatoid arthritis, and it has very little in the way of toxicity. Importantly, in keeping with this idea that blocking IL-1 might be useful to prevent progression of cancer, it's actually been shown to prevent the development of lung cancer in patients at risk for this. And in multiple myeloma patients, myeloma is another blood cancer, somewhat like chronic lymphocytic leukemia. It's been shown to slow the progression in some patients of multiple myeloma by almost 10 years. So at Sunnybrook, we're just about to open a study in patients in the watch and wait period of time to see if injecting ANAKINRA for 7 months will help out. Will it slow disease progression? Will increase immunoglobulin levels? So this trial is basically for anybody who's on the watch and wait period, but expected to eventually need treatment. So we've got to exclude that group of patients that really have benign disease. We want patients who are just on the watch and wait phase. We can almost guarantee they'll need treatment. Treatment may still be years away, but it's not never. And so these patients can be identified by having the unmutated IGHV status, by having enlarged lymph nodes or spleen, by having a circulating CL count greater than 30 times 10 to the 6 cells per mil, or whose IgG levels have fallen below 8. And these patients will then inject ANAKINRA for 7 months at 1 of 3 doses. And then, as I said, we'll look for a response. It may not work, probably won't work, but the whole point is it shouldn't do any harm. So that study should be open soon. And again, if you're interested in something like that, or I know of patients who are interested, we'd be happy to talk to them or talk to their physicians about that. So I think I'll conclude there and be happy to take any questions.